Good morning, good afternoon, good evening, wherever you are in the world. I believe this video is going to be released on Tuesday or Wednesday, whichever I am deciding to schedule it. So happy Tuesday, happy Wednesday, whatever the case may be. So I am going to do some questions. We're going to walk through these questions as if we are taking the MFT National Exam, Disruptive Impulse Control and Conduct Disorder. I found some questions that I would like for us to walk through together so that we can get kind of used to some of the language and some of the terms that you need to be able to identify when it comes to your practice questions, and when it also comes to the real live exam. You know how to distinguish between IED, CD, and I think I've already released the video for these disorders, and that is why you are now seeing these questions. If I have not, don't quote me on that, because I am trying my best to get as much of these videos off before I leave for my vacation, because I want you guys to still have access to me even though I'm not here. So all right, let's get started with the first question, and we are treating these just like I said as if we were taking the real live exam. Okay, feel free to pause the video, see if you can answer the question yourself and come up with the best answer before I reveal the best answer. Which of the following symptoms best differentiates conduct disorder from oppositional defiant disorder? Now, this question is simply asking for what? The differences between the two. So let's look at the answer responses. A says refusal to comply with adult requests. Okay, all right, let's take a look at the rest of them. B says frequent temper outbursts. C says physical aggression towards others or animals. Or D says argumentative behavior with authority figures. Now, let's walk through them. Refusal to comply with adult requests. Is that both conduct disorder and oppositional defiant disorder? Yes, it is, right? B says frequent temper outbursts. Is that both conduct disorder and oppositional defiant disorder? Yes, it is. C says physical aggression towards other or animals. Is that both conduct disorder and oppositional defiant disorder? No, it's not. But let's take a look at D. Argumentative behavior with authority figures. Is that both conduct disorder and oppositional defiant disorder? Yes. So the difference between conduct disorder and oppositional defiant disorder is physical aggression towards other or animals. Physical aggression towards other or animals only comes with conduct disorder. You do not see that in oppositional defiant disorder. And if I've already released the video, you've seen in the video regarding conduct disorder and oppositional defiant disorder, that oppositional defiant disorder, they are like little assholes. They are annoying. They don't want to do what you tell them to do. They don't want to follow your instructions. They are very argumentative. C is the best answer for this question. Alrighty. A 16-year-old has been caught multiple times starting fires and expresses excitement while watching the flames, but shows no remorse. Which diagnosis is most appropriate? Alrighty, let's go back and look up at the question. Starting fires, expresses excitement while watching the flames, shows no remorse. Which diagnosis is most important? Alrighty, now, conduct disorder. The problem with conduct disorder is, in conduct disorder, they do like starting fires. The person does like to start the fires, but they sometimes feel guilty, and they show just a little bit of remorse afterwards, right? So A can't be right. B says pyromania. I like that one, but let's look at the rest of them. C says antisocial personality disorder. Now, here's the thing. You cannot be diagnosed with antisocial personality disorder at the age of 16. You must be 18 years old. C is out, okay? D says intermittent explosive disorder. Okay, here's the thing about intermittent explosive disorder. When you have intermittent explosive disorder, that person is aggressive towards property, aggressive towards other people, and the situation is like grossly inappropriate to how this person is responding to the situation. That's not being seen here, right? So D is out. The best answer that we need to be looking at is pyromania. So a person that is diagnosed with pyromania, they get gratification. They love they express like this feeling of like euphoria, like when they're doing it and even after, they're doing it. So B is the best answer. It is pyromania. Okay. A therapist is treating a 13-year-old male with conduct disorder. Which of the following is the therapist's primary treatment goal in early intervention? Okay, now let's go back and look at it. we have he's 13 years old. He's diagnosed with conduct disorder. We're looking for the treatment goal as an early intervention. So now it's like we need a treatment goal as the early intervention, right? We're just getting starting with this person. We need to intervene and we need the goal for something that's early on in therapy, right? A says to identify and treat comrade anxiety. My issue with A is nobody said anything about anxiety. Get rid of it. B says to reduce aggressive and rule-breaking behaviors. Okay, let's take a look at the rest of them. C says to explore early childhood trauma. My issue with C is we got something that's going on right now, right? And we need an early intervention. An early intervention, we can't be digging in the past for this type of question. We need something that's like right now. He's got conduct disorder. Digging in the past about his childhood trauma is not gonna help me, right? It's not gonna help them, right? That's my issue with C. So we get rid of C. D says to promote emotional intelligence and mindfulness. Now, I can't actually tell you like, oh, well, that's wrong because it's this, that's wrong because it's that. It just doesn't sound right. I'm just gonna go out and say it just doesn't sound right. Because the only answer response that matches conduct disorder is B. Rule-breaking behaviors and to reduce aggressive behaviors, right? The only one that matches conduct disorder is B. It's the only one that makes sense to me. So B is going to be the best answer. Even when it comes to conduct disorder, they break rules. They want to stay out of all types of nights. They want to do whatever it is they want to do. B is the best answer for this question. Which of the following client presentations is most consistent with intermittent explosive disorder? Now, pause this video if you want to. See if you can answer this question. Find the best answer before I find the best answer, right? So we're thinking now when we see a question that's asking us like what presents with this, we're now thinking about IED. What are some of the core features of IED? That's going to lead you to your best answer. A says chronic irritability and frequent arguments with family members, right? When we see something about frequent arguments, what diagnosis are we thinking about? I'm not going to answer that. You answer it, leave a comment, and let me know. When we hear frequent arguments and irritability, what diagnosis do we think about? B says multiple episodes of verbal or physical aggression disappropriate to the situation. That sounds nice, but let's look at the other ones. C says persistent theft and lying without remorse. There's another diagnosis there in C. What does C match with? What diagnosis is C talking about? I'm not going to answer it. I know you can find the answer. Leave me a comment, leave me a message, and let me know what that diagnosis is. D says a pattern of running away and staying out all night without permission. Oh, there it is. There's another one. There's another one that's showing you a diagnosis, and I want to know what do you all think A, C, and D is the diagnosis for? And let me know in the comment section. But this answer is going to be B. The best answer is multiple episodes of verbal or physical aggression disappropriate to the situation. Again, with IED, they are having these huge reactions to a small situation. You just stepped on my foot and you didn't say excuse me. Now I gotta fight you. Think about that for IED, right? It's verbal and physical aggression. It does not match the situation. Small situation, but you have a huge response to it. Is IED. Think of it that way, okay? A therapist is working with a 15-year-old referred by the juvenile court system for repeated theft and aggression at school. The teen appears detached, has little emotional response when discussing violent incidents, and has a history of harming animals. The parents report that these behaviors began before the age of 10. What specifiers should the therapist apply when diagnosing conduct disorder? This question is asking you about the conduct disorder specifier. If you have watched my videos on these diagnoses, you will be able to find the best answer. I also, in that video, I taught about if it's before the age of 10 and then if it's after the age of 10. Those are how you're going to tell the difference between those specifiers of conduct disorder. Take a look at A, childhood onset type with limited prosocial emotions. Okay, sounds good. Let's come back to that one. We know that that's a specifier. B says adolescent onset type with callous unemotional traits. Now, B is also another specifier, but let's take a look at the rest of them. C says early onset antisocial personality traits. I have never heard of that diagnosis before. I don't know if it's real. It could be real. It could not be. It doesn't sound like it's real to me. But I'm going to get rid of C because it doesn't sound right. D says intermittent explosive disorder with conduct features. Again, I've never heard of that one either. It could be real. It could not be real. I have no idea. I'm getting rid of it. C and D are definitely getting rid of because they don't stick out to me as the specifiers for conduct disorder. If we take a look at B, B says adolescent onset type, but the symptoms and the behaviors occurred before the age of 10. So it cannot be the adolescent onset type. It has to be the childhood onset type. If this vignette would have said the behaviors began after the age of 10, then it could have been adolescent onset type. But the best answer is A because the behaviors began before the age of 10. Those are the difference between your specifiers for conduct disorder. Now, in treating conduct disorder, what is the most significant prognostic factor in determining long-term outcome for an adolescent client? Now, this is one of your you just gotta know. If you know, kind of like questions, right? But if we go back and look at it, significant prognostic factors in determining what is going to be the long-term outcome for an adolescent client, right? Meaning, at what age did the conduct disorder symptoms start that might lead them to being diagnosed with antisocial personality disorder? That is the long-term outcome in which they are speaking about. Because what? If the behaviors and the symptoms began before the age of 15, they are going to be diagnosed with, they can be diagnosed with antisocial personality disorder at the age of 18. Right? So let's look at A, the frequency of school suspensions. No, that doesn't have anything to do with it. The presence of camaraderie with ADHD, that has absolutely nothing to do with conduct disorder. Those are two separate diagnoses. They're two separate, so they don't make any sense. C says the age of onset of conduct symptoms. That makes sense to me. But let's look at D. Whether the client expresses remorse during therapy. That doesn't have anything to do with it. We are speaking specifically about the long-term outcome for this client when it comes to treating someone with conduct disorder. The best answer here is going to be C, the age of onset of conduct symptoms. Because if the age of onset of the conduct symptoms start at a certain age, then most likely they can be diagnosed with antisocial personality disorder. That is that long-term outcome that they are speaking about in this question. I know it's kind of one of those questions where it's kind of like, I guess you just gotta know. You can read between the lines all you want to, but make sure that you are going to at least match that answer with something that is similar to what the question is discussing, right? Similar to what they're discussing. Frequency of school suspensions doesn't have anything to do with the long-term outcome because you're not going to be in school for all of your life and getting suspended, right? That's not going to happen. They want long-term, something that's going to happen in the future. What can you be diagnosed with in the future if you are continuing with these symptoms, right? And what else can they turn into, okay? I hope that makes sense. I threw this question in there because it's kind of like, how can I teach this? Do I know how to teach this? Can I make it make sense to them, okay? A therapist suspects intermittent explosive disorder in a 17-year-old client, but is considering other diagnoses. Which of the following features would most clearly rule out IED? And I like these kind of questions because this question is asking you, what do I need to get rid of, right? What can I get rid of that's going to clearly rule out that my client does not have intermittent explosive disorder? That's how you have to relook at these questions, right? A says aggressive outbursts that are not premeditated. Okay, let's take a look at B. Repeated outbursts that occur at least twice weekly for 3 months. Okay, let's take a look at C. Aggression that occurs exclusively during episodes of intoxication. Okay, let's take a look at D. Verbal and physical aggression that causes significant distress. Now, let's go back and take a look at all of these. And again, we will take a look at this question again and kind of like dissect it so that it makes sense to us. You as a therapist, you think that this client has IED, but I'm looking at other diagnoses as well. Which of these answer responses will tell me that it's not intermittent explosive disorder? If you take a look at A, B, C, and D, there are 3 of them that matches the diagnosis of IED, and 1 of them does not. That's how you're going to get to your best answer. A says aggressive outbursts that are not premeditated. That is IED. B says repeated outbursts that occur at least twice weekly for 3 months. That's IED. D says verbal and physical aggression that causes significant distress. That's IED. The only one that is not IED is C, aggression that occurs exclusively during episodes of intoxication. That is not a symptom. That is not a core feature of IED. If it is occurring during intoxication, if it's occurring during other situations that will make you think that, oh, it could be schizophrenia or it could be bipolar, it's not IED. Think of it this way. If this question would have said, which of the following features would most clearly rule out IED? And one of the answer responses were, if the client sees hallucinations, that would have been your answer response. Because with IED, hallucinations and disorganized thinking does not come with IED. So you would get rid of it. That would be your best answer. Okay? This question is simply asking you, which of these symptoms that are presented is not IED? And I know sometimes these questions can get like tricky and it's like, oh, I don't know what they're asking for. I don't know what they mean. Just slow down. Try to reframe the question in the way that you understand it. It's asking you to get rid. There's one that needs to be gotten rid of. And it's C. Because if aggression occurs when you're intoxicated, that's not IED. Okay? While working with an adolescent diagnosed with conduct disorder, the therapist learns the client has been setting fires and experiences a sense of relief afterward. The client denies any intention to harm or gain from the fire setting. What is the most clinically appropriate response? A says maintain the conduct disorder diagnosis and increase behavior monitoring. Okay. B says add a diagnosis of pyromania and refer for a risk assessment. C says refer the case to Child Protective Services and terminate therapy. D says focus treatment on trauma history and delay any formal diagnosis. Okay, now here we go. Let's go back and look at the question. The client is setting fires. He has a sense of relief afterward. He denies any intention to harm or gain anything from the fire setting. What is the clinically appropriate response? A says maintain a conduct disorder diagnosis and increase behavior monitoring. Now, there are two different diagnoses that are being presented in this question. It's not just conduct disorder. With conduct disorder, remember, I think I talked about this in a question in this video. With conduct disorder, the person, if they do set the fire, it's not like it's a sense of like relief. They don't get the gratification. And usually a person that has conduct disorder and setting a fire, there's intent. They purposely are doing this. A person that has pyromania, they don't need any intention. They just do it because they get the gratification from it. They don't need a gain from it. Their gratification is their gain from it. If you take a look at C, refer the case to Child Protective Services and terminate therapy, that can't be right because they're asking you for a clinical response. There's no need for you to refer the case to Child Protective Services for what? It didn't say that he lit a kid on fire or they burned down somebody's house or tried to burn up their parents or something like that. And then you probably need to be calling 911. So there's no need to contact Child Protective Services. D says focus treatment on trauma history. Again, why are we digging in the past? This person is setting fires right now and might try to set one in my office if I'm not careful, right? So there's no need to dig into the history or anything. We need something presently right now. Take a look at B. Add a diagnosis of pyromania and refer for a risk assessment. Pyromania is being presented also in this vignette. Remember, a person that's diagnosed with pyromania, they don't need an intent. They don't need any type of gain behind it, no monetary gain or anything. They will just do it because they get the gratification from doing it. Before and after they've done it. Okay, keep that in mind. Alrighty, this is the last one. A 14-year-old male is referred to therapy after being suspended multiple times for fighting and stealing. He shows no remorse and blames others for his actions. During family sessions, his parents describe long-standing defiance, deceitfulness, and destructive of property. What long-term risks should the therapist monitor closely as the client ages? So again, this is the one again where we're thinking about the future. Long term. We're thinking about long term. He's 14 years old now, okay? A says and increased risk of developing generalized anxiety disorder. Now, if we go back and we take a look at what's presented in the vignette: fighting, stealing, no remorse, blames others for his actions, defiance, deceitfulness, destruction of property. Doesn't sound like anything for generalized anxiety disorder for me, so we get rid of A. B says escalation into bipolar disorder. I have yet to see anyone that is diagnosed with conduct disorder and then it changes to bipolar disorder. I have yet to see that, so I will get rid of B all in all. C says transition to antisocial personality disorder in adulthood. There it is right there. That question, that answer response, and I'm talking about the long term. If you are able to identify in that vignette that this is conduct disorder that they're talking about, you know long term is going to be the antisocial personality disorder. But just for shits and grins, D, likelihood of obsessive compulsive disorder. None of that stuff has to do with OCD, so we're going to get rid of it. Your best answer is C. The transition to antisocial personality disorder in adulthood is the long-term risk that we would be thinking about because the vignette is presenting conduct disorder symptoms. Okay? I hope this video makes sense to each and every one of you. If you have any questions, comments, or concern regarding the questions that I just went over, please feel free to leave me a comment and I will get back to you as soon as possible. Again, when it comes to IED, conduct disorder, ODD, make sure you know the difference between the terms, you know the difference between the core features. What does each of these diagnoses come with? What are they tailored to? It is best to know that. Alrighty, I will be releasing this video sometime Tuesday night. So in the morning, you will see a video released for the diagnosis, and then that night you will see videos being released for the questions regarding that video, if I can remember to make sure I'm doing them in order. Alrighty, I will talk to each and every one of you later.